25-year-old, type 1 diabetes. It's in emergency room by the family. Confusion, lethargy, abdominal pain, nausea, vomit. So you have. What is your diagnosis? What do you think is wrong with this patient? What you need to do to prevent any complication for this patient? 65 years old, left hip replacement, discomfort on the affected leg when he walks. Anything wrong with this patient? What is the diagnosis? What is going on? And then you can come up with your plan of care and fix this patient. 4-year-old boy, forceful, lumbilious emesis, spasms after every meal, palpable abdominal mass. Figure out what is wrong with this patient. Remember, age is not a factor. Don't care about age at all. When 4 people come to you, whether you're a 1-year-old, 2 weeks old, no, everybody is important. So just because it's a 4-year-old, that doesn't mean it's the most important of all. So don't worry about it. It's not the most important. Don't get trapped easily. 35-year-old, positive blood culture for MRSA bacteria with temperature of 101.5, white count 20,000. Is receiving antibiotic. Did you figure out what is wrong with any of them? 4 patients know what is wrong with them. If you know what is wrong with them, all the questions, if they ask you, you'll be able to fix it. That is the key. If you don't know what is going on, you can't figure out. Make a diagnosis for this patient who is 25-year-old type 1 diabetes with all these symptoms. Are those symptoms worrisome? If it's worrisome, what does it tell you? That this is 5-year-old who just had a hip replacement and he's having pain when he walks on that leg. Is it worrisome to you? And a 4-year-old non-bilious emesis, forceful every time he eats, and he has a mass in his abdomen. And somebody with a positive blood culture, that came out to be MRSA. His temperature is 101.5 and he's receiving vancomycin for the treatment in his white count of 20,000. What do you think is going on? You be the judge and you make the diagnosis. There's this concept you have to know when you're testing. So these are simple, straightforward questions. And I know you know what they are, what each of them, and what problem you need to do to fix it. Now, what is the potential diagnosis? What do you think number 1 is going through? Number 2, number 3, number 4. If you look at the parts very carefully, we'll give it to you. Type 1 diabetes that is confused, lethargic, is having abdominal pain, nausea, and vomit. These are usually signs of dehydration. What is called it causing the problem is now confused and lethargic. This is consistent with the DK, signs of symptoms of DK. That's what is going on with this patient. Left hip replacement, and he's having pain of the affected leg when he's walking. This is usually expected, but it can be other things too. Or we can say pain issue on the post-surgical pain, basically. That is problem. It can be some bad stuff if you continue. You got to figure out if he's walking properly, if you know how to take steps with this. If you can manage his pain, it's a safety issue. He's going to fall down. 4-year-old boy, forceful vomit, your bad weight. 3, non-bilious, your bad weight. emesis every time you eat. And then it's a palpable mass. This is what? Pyloric stenosis. And you have 35-year-old whose blood pressure is positive for MRSA, is being treated for. The this is what? Bacteremia. There's an infection in the blood. So we call it bacteria in the blood. It's bacteremia. These are the diagnoses for each of them. And based on them, you can see when you do prioritization, I have blood infection, pyloric stenosis, post-surgical pain, somebody is in DKA, is confused and lethargic. You can use that idea to make your prioritization easy. Don't worry about time, age, nothing. This is all diagnosis, and out of the diagnosis, what is happening to them? And you can figure out. Just because the kid is vomiting, we don't see any signs of dehydration. Of course, it's at risk of dehydration, but the question, the way it's framed, it's just telling he's vomiting. We don't know what is going on with them. You should not just pick it because you know it's pyloric stenosis. Okay, so this is the problem. This is the diagnosis. You have to see what else you have to do for this case. Now, who do you want to see? I've already given you the clue. Who do you want to see? If you want to see one, right? This is 4 key patients in the case form, but if you have 1 second, you have to be sharp. And when you're sharp, you take care about what? Breathing problem, electrolyte, shock, hypothermia, okay, hypoglycemia, airway, lethargy, and pain issue. The pain related to life, limb, eyesight. Which of those problems is worrisome? Well, I see some really bad words here. Confusion, lethargy, associated with DKA. I'm not happy about it. I don't see any worrisome words here. This is pain at the site of the surgery. Yes, this patient is at risk of something, but based on what they've given me, I don't see any worrisome. It's at risk of having a bad problem if it's continued. Same as this, yes, infection, sepsis. This can progress if you don't take care of it. But who you don't have time with is somebody who is lethargic, somebody who is confused, and is still getting sick. That's how you do prioritization. And therefore, the most serious of all is number 1. Number 1 is the one you need to see first. It's really bad. It's DKA and it's getting worse. 3 is not a big problem. We will deal with it later. We need some hydration. But there's nothing in the stem of the case tell you it's getting sicker. It's just telling you it's having symptoms, but there's no evidence of having end organ damage. This patient is having end organ damage, confusion, and lethargy. The dehydration is already affecting. It's in the bad stage. So that's number 1. Number 1 needs to be seen. Now name 1 priority complication for each of them. Like I said, this kind of case study requires a lot of content. What kind of complication do you think this patient will have? Number 1. Client 2, what kind of complication? 3 and 4. You just have to list one of them and figure out what complication they're going to have. If you have DKA, you're already lethargic and confused. Severe dehydration. Okay. It's going to have severe dehydration, and they will manifest themselves in neurological symptoms. This is the biggest problem with these patients. So you have to fix this problem. And this is the major complication. They're getting dehydrated from excessive loss of fluid due to the hypoglycemic symptoms. And that's why they're confused and lethargic. If you don't do that, go into coma. This is one of the complications. For this patient, post-surgical pain. Yes, he has pain. If you don't manage the pain, you're going to fall and break his leg, and he will need another more surgery. Let's take a strategy. You can see that this is one of the complications associated with that. Now, what about this patient? You already know, pyloric stenosis. This is the problem. They have hypertrophy of the tolerance. They eat, food cannot pass through, and they vomit. It's non-bilious because it does not pass the pyloric. As soon as it passes the pyloric, it goes to the duodenum, and it's bilious. Here, there's no bar. Kid will continue to vomit and get dehydrated. Content you have to know is the electrolyte balance. Because the vomiting acid, their acid goes down, so they are what? Alkalosis. They're going to vomit sodium chloride, so they have low sodium, low chloride. The sodium will exchange with potassium. The potassium will become low. So what we have? Hyponatremic, hypochloric, hypokalemic, metabolic alkalosis. These, you have to know these deficiency in the acid-base status if somebody is vomiting. Whether you have NG tubing or anything you do is the same thing. Hyponatremia, hypochloric, hypokalemic, metabolic alkalosis. You just have to use pathophysiology to be able to do this without not memorizing. Yes, it's going to get dehydrated. So dehydration is the bad thing. Of course, you should be able to pour out all the signs and symptoms of dehydration. Sinking fontanelle, mucous membrane dry, hypertension, creatinine is going to go up, BUN is going to go up, the red cell is going to go up, hematocrit is going to go up. All the signs and symptoms your body give you. We're not talking about dehydration. I'm teaching you so that you can see how they can go left and right. I can list a bunch of signs and symptoms without not memorizing because of the concept. You'll be able to list it so that when they give it to you, say, oh, these are the signs and symptoms of dehydration for this particular patient. This patient is going to get septic. Okay, if you don't treat it. But what is the major complication of bacteremia? What do you guys think? If you have bacteremia, bacteria in your blood, what is the major complication apart from sepsis that we all worry about? This is the reason why we treat you so that when there's a blood, you have infection in your blood, you prevent that. If you have dental procedure that goes into your blood, you prevent that because we give you antibiotic. Why do we do that? What is the major complication associated with bacteremia? And this is what your doctors worry about all the time. That when you're bacteremic, you worry about endocarditis. The inflammation of the cardiac lining, you get infection by the vegetation of the bacteria, and it goes there. This is what we worry about. Endocarditis. It's not good because all the blood goes to your heart and cause problems. These few questions, bunch of content, I'm trying to pour out to you guys so that you can know that you should not limit yourself. You don't know where they will take you. So just master them so that whatever they bring to you, you can branch. Science is not limited. It branches from one place to another. So that's the point. Now, client one, we know he has a DKA. What is happening? Which of the following plan of care is appropriate or not appropriate for client one? What do you do with DKA? Straightforward. Go back to the pathophysiology. This is your cell. Your cell, you have potassium here. Usually you have more potassium here. What is the problem with DKA? These are type 1 diabetes. They need what? Insulin. They cannot make one. When they're sick, they try not to eat. They say, if I'm not eating, then I'm not taking my insulin. But they forget that this potassium, there's some potassium, and there's glucose floating around. This can only go into the cell by insulin. If there's no insulin, potassium goes up. There's no insulin, glucose go up. This is the problem of DKA. Lack of insulin leads to what? Hyperkalemia and hyperglycemia. When the glucose build up, your body said, I don't like that. I'll get rid of it. What happens? Leads to excessive diuresis. So you lose a lot of water and it causes a dehydration. Your body said, well, I still need glucose. The cells, they say, I need glucose to be able to what? Generate energy. What would they do? They start using fats, protein to break it down to what? Ketone bodies. And it's this generation of ketone bodies that lead to the acidosis. Of course, I got to get rid of this ketone. This go to your lung. And therefore, when you smell them, they smell like fruity. You smell their urine, you see ketone. The lung said, I need to get rid of these ketones. How would they do that? Well, they're going to get rid of your acidosis by doing what? Respiratory alkalosis. Straightforward. When you have metabolic acidosis, you convert it into what? Respiratory alkalosis. It's opposite. So they start breathing something you've seen before, Cushman breathing, deep, rapid breathing in order to get rid of what? The CO2 to generate respiratory alkalosis to correct for the acidosis. That's all. DKA 101. Now, when they come to the emergency room, you have to know this. When they come to the emergency room, potassium is high, glucose is high. But what is your priority? Number one, hydration to correct the dehydration. So give them fluid first. Okay, you give them normal saline, large amount bolus, followed by the insulin. Then after you, don't worry about the potassium. Potassium probably will be 5.86. Don't worry about it. Don't correct it. Don't give them KSLA. Don't give them anything to drop the potassium. If you do that, you're going to kill them. The potassium is going to go down as soon as you give them insulin. And then after bolus, insulin, check their finger stick. When their glucose is close to 250, give them D5W and add in potassium to their fluid. So now it came in with hyperkalemia, but you're giving them what? Potassium. That is the content. The potassium will go down as soon as you give them insulin. But when you continue to go down, you get to the point that you have to replace more potassium. So it's close to the point you're giving them glucose. That's when the potassium, that means the acidosis is being controlled. And that's when you have to give them back more potassium, even though they come in with hyperkalemia. The key, if they can trap you, if potassium is still normal, you still need to give them potassium, replace potassium, because the potassium will go down when you give them insulin. That's the key. And this is DKA in 5 minutes. Therefore, for this patient, check his glucose. You got to check his glucose. We don't give them insulin first. When you give them insulin first, they get into trouble. Normal saline after insulin, no. You give them insulin, then you give them normal saline before insulin. This patient needs to be in the ICU. You need to be in cardiac monitor because of his potassium. You need to replace their glucose, like I told you, when glucose is like 250. And you don't correct their potassium from the initial BMP. Initial BMP will show potassium 5, 6. You can give them calcium gluconate to protect the, the heart, but never give them anything to drop the potassium All you need is insulin. You go back to the pathophysiology. You give them insulin, you correct everything after dehydration. Remember, if they're doing the Cushman breathing, don't let them breathe into a bag because they're trying to get rid of the metabolic acidosis. So let them do that. That is the adaptation to correct the problem. So for this one, indicated. But this is the simple content for DKA to be able to understand what is going on. That is, if you need more of this, you understand it pathophysiologically, you can answer any question no matter what they throw at you. If you memorize it, you won't be able to do that. So don't memorize it, understand it, so that when they put this table for you, you can see, oh, do I do this or not? Don't correct potassium from the initial BMP. Now, number 2, the guy who had a hip replacement, client 2 is 12 hours after surgery. Which of the following is a priority? This is a hip replacement content. Okay, there's only 2 things you should worry about when you have hip replacement. Hip replacement, no flexion, past 60 to 70 degrees. No, 60 to 90 degrees. You should not do that. And the 2 legs should not come together. So no addition. I call it subtraction. Abduct the legs away from each other. The legs stay here. So you got to put something here to keep the legs apart. Otherwise, the leg will dislocate. Any question they're going to give you, if it's related to hip replacement, if you remember these 2 things, you pass. There's no question they're going to give you that you don't understand. Every question will be based on this concept that make sure there's no flexion 60 to 90 degrees past that, and then the 2 legs are not coming together. So which one is a priority? If you cross your leg, the 2 legs are together. If your head out of the bed is greater than 90, I told you there's no reflection. The temperature is 101, 100.5, it's 12 hours. That's acceptable. So there's no sepsis here. Monitor blood glucose is irrelevant to this problem. So the most priority is to put the wedge between the legs so that the legs don't come together. Like I said, keep the legs apart and don't flex past 60 to 90 degrees. This is the concept. Every time they give you a question on hip, if you write this down, answer each question in the lines of these 2 problems. Once again, hip replacement, flexion 60 to 90 degrees, it should not happen. It should be less than that. And then you should not bring the 2 legs together. Therefore, you can cross the leg together. Now, the same client number 2, what is happening? 45 here, the same thing. Client 2 is ready to be discharged. Which of the following statements need immediate intervention? Now he's going home. So which of these, when he say it, it has to be, you got to intervene. Keywords, immediate intervention. That means saying something bad. Yeah, the hip replacement. It's a mild bruising or redness will occur at the injection site, buzzword. Injection site for the medication to prevent clot. He had hip replacement. Most of them will go home with anticoagulation. And I'm trying to let you pay attention to detail. And this anticoagulation is injectable. There's only few anticoagulation that is injectable. It's heparin, not the drip, not the sub-Q. We're going to use lower molecular weight heparin. So lower molecular weight heparin, that is Lovenox or enoxaparin. So that's what is going to go home with, the most likely. They are both heparin, But the sub-Q, like the 5,000 units, it's usually not, is a prophylaxis. It's not enough. And we usually don't send people home with heparin sub-Q. The heparin sub-Q, we send them on enoxaparin. And so when you inject it, yes, of course, you're going to have mild bruising and redness at the site of injection. When you inject it, if this is the belly button, 2 centimeters from the umbilicus. What angles do you go? 90 degrees and 45. If you can pinch more than 2 centimeters, yeah, 90 degrees is good. Sub-Q, not IM. If you cannot pinch more than 2 centimeters, so less than 2 centimeters, 45 degrees. This is sub-Q. And that's what you inject. Small bruising. So this does not need intervention. I will need to eliminate green leafy vegetables from my diet when on injectable anticoagulation, test-taking strategy. I just explained it to you that way. The only medication, most of them, only few are injectable. The most likely injectable one is going to be enoxaparin. Enoxaparin is heparin. Heparin does not affect vitamin K dependent factors 2, 7, 9, and 10. What affects these factors are coumadin. And coumadin, when you're on it, yeah, that's when you can modify your leafy vegetables or whatever you want to do. But most of the time, you stay the same. There's nothing related to injectable anticoagulation. You don't have to eliminate your green leafy vegetables. You don't have to change anything. You just do what you get to do. So this is the test in case they start using this way. Injectable anticoagulation has nothing to do with vitamin K dependent factors. So leafy vegetables, or you don't have to do anything like that. So this one is a what? Need immediate intervention. We got to do that. I will need a wheelchair at home. One key fact, okay, concept with hip replacement is walking. If you're not walking, you're not going home. You don't get discharged if you are not walking. So don't expect to be going home if you walk, you are not walking. Therefore, what you need to a wheelchair at home. We're not sending you home if you're not walking. So if you want a walker, a wheelchair, yeah, we need to have intervention. I will perform leg exercise when watching TV. Yeah, we want you to do isometric exercise to improve your quadriceps and quadriceps to help with your strength. I already told you the concept, 60 to 90. You should not flex past that. Okay, this is wrong. And therefore, when you're sitting in the toilet, you have to modify your toilet. Toilet razor is very good so that you don't have to bend. And so this is good. So this is good. That one does not need intervention. So the only two that need intervention is 2. Performing leg exercise is good. Adding toilet razor is good. You don't need a wheelchair. You don't need to eliminate green leafy vegetables from your diet. And then you're going to have bruising and redness at the injection site. So 2 and 3 are the one that need problem. Now, I think the last one. I said, this is all just a concept to help you. Now, try to see if you know this, right? Number 4. You see, I'm going back and forth. Don't worry, if they can do the same thing, go back and forth. They can pick one of the case, and then so we go find complication with one of them, talk about one of them, but there's 4 of them in the case form. So client 1. Client 4 returned to the emergency room 3 weeks after discharge with night sweats, recurrent fever, splinter hemorrhages. What should the nurse expect on exams? And which one finding is a priority? Look at it. So we already know the problem. It's a 35-year-old positive blood culture with the MRSA with temperature of 100.5 and it's getting vancomycin. I told you one of the complications you should worry about anybody with bacteremia is what? Endocarditis. And therefore, coming back 3 weeks, here's what? Night sweats, recurring fever, splinter hemorrhage. What does that tell you? Those are buzzwords. Does that ring a bell? Check out adaptive ankles. You see a video that can cover all these things easily. What does it tell you? These are signs and symptoms of endocarditis. And that's how they say questions. Simple, straightforward. Every question should have one or two buzzwords at most in order to lead you to the diagnosis. This should tell you that. You know how to make a diagnosis of endocarditis. What are the things you should look for when somebody has endocarditis? If somebody has IV line that is infected, and you're trying to figure out if they have endocarditis. It's straightforward. Ask Jane. Jane is the problem. So I call it from Jane. She's the problem. She brought everything to you. So if you ask Jane, she will tell you what to do when you're looking for signs and symptoms of endocarditis. The F, they're going to have fever. The R, they're going to have rot spot. If you look into their eyes in the retina, you see a red spot there. That's rot spots. O, oslo node. If you look, this is painful. It's painful. This is fine on your fingertips, okay, or on their toes. So this is fine in your toes or the fingertips. That's oslo nodes. They are painful. The if you listen to them, you're going to hear a murmur. And then when you go to Jane, he said, well, this is Janeway lesions. This is found in their palms and their sole of their feet. This is not painful. It's not painful compared to the oslo nodes. The A, they're going to be anemic from chronic disease. So anemia of chronic disease. And if you look at their fingernails, that's what we call it, splinter hemorrhages. This is splinter hemorrhages. And E, we call it emboli. What does that mean? The blood goes to the heart, and the heart pushes the bacteria everywhere. The bacteria become emboli, like a debris. It can go into your brain. It can go to your anybody, any part of your body and causes problem. This is the key. Straightforward to understand endocarditis. That is the concept. It go everywhere. So every part of the body, and if you look at their body, they may have petechial hemorrhages all over. It's because of these emboli being deposited. That tells you the emboli can go any places and it can cause problem. What would they need? Long-term antibiotic for the management. So what should the nurse expect? Of course, anemia, the rot spot, the Janeway lesions, the oslo node. As this step scares you, is concept and critical thinking. I just told you it can go everywhere. It can go into your vessels in your foot, everywhere. It can go to your kidney can die. Your spleen, if I put splenic infarct, it can go there. It can go your brain. It can go any portion. It can go to your stomach. It can go to your GI tract. You can have infarct. The kidney will have infarct. Spleen will have infarct. The liver will have infarct. They can die from it. So your toe, okay, you can the blood go to the blood vessel and you go to your toe and causes ischemia there, like um, the peripheral artery disease. It just occlude the vessel and no blood go there, and so you can get gangrene of the toe, right? You can also get facial drooping because you're going to get stroke. These two, they are complications. So you don't see them that much. Okay. They become priority that, oh, something bad is happening. These four are consistent with endocarditis, but these are complications. 1, 2, 3, 4 are what is related to endocarditis. When you see gangrene toe, facial drooping, these are complications of endocarditis because it has emboli to bad structures that are very, very important. Your toe and your facial drooping. So which one is a priority? It's number 6. That means if I see facial drooping, you have stroke. And that is bad. 7 questions, 4 cases, just to tell you that, I mean, this is what they can be doing. Give you short cases, but try to like make it in a long case, but full of content. So please, just make sure you know your stuff before you go into the test. Don't rush, master it. You see, the whole thing I gave was full of information you need to know. Nothing beat content. There's no way. I can tell you. I mean, if you know stuff, I mean, there's nothing you can say that you don't know how to figure it out. You have to use that and a little bit of tactical strategy. But you have to know what is going on first before. Like I said, number 7, you see, I give you 3 buzzwords. You got to put 1 and 2 together and say, oh, this is endocarditis because he has bacteremia. And I know the signs and symptoms of endocarditis. That's all. And you answer the question. Take care of yourself and happy Thanksgiving to you all. All the best of luck. Adapted this out.